Hi, everyone. I'm Dr. Jennifer V. Brown, your stroke specialist. And today we're going to talk about the appropriate hand placement to improve sit to stand after stroke. Now, where you place your hand on the stronger side dictates a lot of things, especially since you're weak on one side after the stroke. It compromises trunk posture. It forces you to lean to one side as opposed to staying symmetrical. Because when you go to sit to stand, you don't stand at a diagonal. You stand in midline forward. It decreases the weight bearing on the hemiplegic side. So as soon as I shift over to put my hand down on the surface to help push up, I decrease the weight on my leg, through the foot, through the thigh on the surface, and any potential that the hand or the forearm has to be weight bearing either on the chair arms or the surface. And it redirects the body movement. As I told you previously, you stand in midline going forward, not to the side. Now, this hand placement causes a lot of problems for some issues related to your arm trunk ratio. If your arms are longer, you will tend to be more bent. But if your arms are shorter, you're going to either curve forward or curve sideways for the hand to touch the surface. So, what do I tell people? The first thing you do is you measure the arm trunk ratio. Let's put something underneath the hands so that you have a little bend in your elbow. You can push off, depress your scapula, squeeze the buttocks, and lift off. Okay? So let's watch the video and see how the placement of his left arm really changes everything for sit to stand, including his base of support. Pay attention to his legs. Notice he leans forward and to the side at a diagonal towards his strong side, and he doesn't stay midline. And when he leans over to that side, the weak leg says, well, I'll just come on over there for stability and I'll squeeze my knees together for stability. But if he had them loaded and his leg could feel that, oh, my muscles can work, I can generate force keeping my knee in aligned with my hip and go up in midline forward to stand. So these are some treatment ideas. First of all, just practice sitting and getting the trunk forward with the arms outstretched in front of you, both of them. Why? Because you're loading your legs. Now, here's the thing. If you have tightness in your low back fascia, called that thoracolumbar fascia, or limited mobility at your pelvis, your thighs may go out. Sometimes I have folks lean forward and try to grab their forearms underneath their thighs. Everybody can't do that because of that tightness in the low back and because of their trunk posture, waist girth, etc. But I really do try to get people forward. If they can't get forward on a chair, then I put their forearms on a high-low table with wheels and they do this. All right, I'm moving the table as they come forward. But the thing is, you have to elongate the trunk, get it forward, and get the hands forward on a surface. And after that, I will allow them to either hold their hands at their wrist, interlock their fingers, or prayer position. It's really difficult to do that because people with a weak arm will end up doing this, and that makes for the trunk on that side elongated. I want the scapula to remain down, but the arms to come up. So sometimes we have to do the genie motion for standing. Sometimes we have to keep our elbows tucked to our trunk and lean forward. And then at the lift off, I let them go out. Okay? So that's what we do with the arms. Now, if I want to get more range in the trunk forward and up and more range in the arm, I use a ladder. And we can start at each rung of the ladder with the forearm in pronation, meaning hand down, or supinated to neutral, and we slide the hands up the side of the ladder. I really do like using the latter. All right. And then I use a pole. Notice I have PVC piping at the top because sometimes I have them push down, but then I reverse the pole and they push up. And when they push up, especially against resistance of the TheraBand, they're strengthening their trunk and they're getting their arm in midline. With the pole, not only do I have them practice holding their arms up here or here, depending on the range of motion at the shoulder, including that scapula mobility, protraction, upward rotation, you all. I'll have them do isometric so they're pushing against that bar. All right. Or I'm trying to push them backwards and they have to stay forward. This is really great for training the horizontal component of sit to stand. And I notice when I'm pushing back on that bar, I can feel their hamstrings tighten up and they're setting their feet in place, getting their ankles back to prepare for vertical liftoff. One more thing, the reason why I like that PVC piping up there, because when they're moving up, the higher they lift off, they're starting to get their pelvis up off of the surface. So hopefully these treatment interventions are great ideas for you to get that arm in front of them and up to help facilitate horizontal displacement in midline forward and then prepare for the verticality of standing. These are some clinical questions I want you to ask. Is the less affected arm shorter than the trunk, causing side bending away from the hemiside? So make sure you measure the arm trunk ratio and either build it up. If their arms are really long, raise them on a surface. Use a wedge. Get their pelvis up in the back. Is the trunk, in addition to the arm and leg, impacted by the stroke? And that's maybe motor weakness or a sensory perceptual impairment. If they feel that one half of their body exists, they're going to be over here all the time. Or I've seen midline shifts where the whole head will shift over to the side, excuse me, in which they see their visual field, right? Is the hemiplegic arm in a synergistic pattern, either extension or flexion? If so, use a towel, use a pool noodle, or something to keep a space here and get it weight bearing on the surface. A box, anything that will help the forearm in weight bearing or the hand in weight bearing if an extension synergy. If I have an extension synergy, sometimes I use cold fruit that are frozen and I slice it in half, put it in a plastic bag, and that coldness helps. And I make sure I put dips in the fruit to so the fingers can be troughed. I also use styrofoam. I slice them in half and I trough out um, ditches, you could say, for the fingers. And I put those in the freezer too so they can be cold. Coldness often relaxes, prolonged weighted cold relaxes versus quick icing is facilitatory. So we want prolonged cold to reduce the tone that you may see in the hand, and that will help with weight bearing. Okay? Remember, I am your trusted source for all things ankle foot orthoses and stroke neurorehabilitation. And don't forget the references. We have to use the evidence appropriately and apply it to our patients to improve clinical outcomes. Thank you for watching. Don't forget, like, share, subscribe. Bye. See you next time.